proceedings. Thank you.
Thank you, respected chairpersons. I'm honored and privileged to be speaking in front of a very, very light and senior chairpersons. And I'm also honored to be here in the cultural capital of India, a city of both processions and city of joy. I'm really happy to know that you do a lot of processions and you remain happy. And I'm also privileged to be speaking in front of my seniors, Dr. Amal Banerjee, Dr. Sarkar, Dr. Chakravarti, Dr. Ghosh, with whom I've been interacting in a national level. And I'm especially thankful to Dr. Chakravarti and Dr. Jyotimari Paul, whom I do not see. He must be busy in the national politics as usual. And I think what is important for us to talk to for next 25 minutes to this very, very learned but depleted audience, and some of them are having the tea, is to see whether we can now have some strategies to prevent the progression of one of the dreadful disease. And I am very clear, I do not have any personal disclosure except for an excellent hospitality given by my friends in a five-star hotel. And also, I was treated to a good breakfast today. Except that, I do not have any conflict of issues. My outline of presentation would be to talk to you about how, apart from the infections which are on the rise, as was stated by my previous speakers, but non-communicable diseases are also on the rise, and we've seen a rapid spread of hypertension, diabetes, and all those. So we're going to talk about the disease burden. Also, I'll talk to you about trajectory of chronic kidney disease, how a specific individual behaves once he's diagnosed as a case of chronic kidney disease, and what are the risk factors associated with progression of CKD. We all know about the risk factors for CKD, but what are the risk factors for progression? And then we'll try to see if we can try to reverse this trend or at least halt this trend of rapidly progressive renal disease. And then there'll be some key messages. Well, we all know around a decade back, we used to call chronic renal failure a term in which the creatinine was more than 1.2 arbitrarily without giving credence to what is the duration of the therapy. But now, for last decade, we are very sure that chronic kidney disease is defined as alteration or dysfunction of the structure or the function which is persistent for 3 months. Even if you have an electrolyte abnormalities, which is secondary to a tubular dysfunction, persisting for 3 months defines it to be CKD. So are the structural imaging abnormalities or a history of kidney transplantation. So what is important is we need to have evidence of albuminuria, evidence of a decreased GFR, persisting for at least 3 months is what will define as chronic kidney disease. And lately, around 5 years back, there was a group formed as Global Burden of Disease, and I was very lucky to be a part of that in the CKD group. That published a series of articles in Lancet about what is the prevalence of various non-communicable disease. And this is a study which was published in Lancet in 2000 study, which talked about global, regional, and national prevalence of chronic kidney disease. And we will see here that the overall prevalence of chronic kidney disease all over the world is to the tune of 9 to 12%. And India also participated in that, and the numbers have shown a significant rise, not only in terms of morbidity, but also in morbidity. And these are some of the, elegant studies done by some researchers in India about prevalence of chronic kidney disease. Dr. Sanjay Agarwal from AIIMS started the trend, and he found that his 10% of CKD patients were diabetic. Hypertension was prevalent 22%. But his criteria was based on a single level of creatinine mode 1.8. Obviously, this was before when eGFR came into picture. Then, of course, there have been some studies, and this was our study which we published in 2009, which said a prevalence of a low GFR to be the tune of around 4%. Subsequently, A.K. Singh from US published his data, and where he found a prevalence to be very high as 17.2%, but this was a voluntary approach. And then, of course, there was a study by Dr. General Verma who described the prevalence to be the tune of around 4 to 6%. Now, why is it important for us to make a diagnosis of chronic kidney disease? Once a diagnosis of chronic kidney disease is made, there is a relentless progression to what is known as end-stage renal disease. Unfortunately, majority of these patients would succumb not only to ESRD, but to significant mortality due to cardiovascular disorders. So, as I said, general prevalence varies from 9 to 20%, but please understand that there is a catch here. Why the incidence is so high is because of the fact we take into account the age, sex, and the serum creatinine. Now, with time, each one of us are aging, though we may not be able to see our age like Dr. Chakravarti sitting here or others, but with aging, there is some decline in renal function, but that is a healthy aging that may not necessarily convert into a chronic kidney disease. So with aging, the difference would be that the GFR is reduced gradually, but when you have a CKD, you have an associated structural or abnormal function in terms of proteinuria. And as I said, the mortality is being very high, progressive rise in CKD, and there's a need to improve current management. And what is utmost important is to detect them early in the primary care staging and halt the progression. Now, if you have a diagnosis of CKD, each person will behave in a different way. That will depend on what is his trajectory. And that trajectory is dependent on various factors, including the etiology, including even in that etiology of nephropathy, what is the underlying diagnosis of FSGS versus the other disorders. If a patient has an ADPKDA, then his trajectory is different. Then his genes also decide how is his trajectory going to be. So we need to understand the patient very well of a chronic kidney disease and have a strategy based on the diagnosis of CKD in this patient. As I said, there are various types of patterns of his rapid progression to renal failure and stage renal disease. And these are highly variable. One person may have a very slow progression to chronic kidney disease. And this is a practical experience. You must have seen a patient of CKD comes to you. After 3 months, the rise is just 0.5 or 1 milligram. On the other hand, we have a patient who shows a very, very rapid decline in chronic disease. So these are some of the strategy. We can divide them into very fast. If there's a rapid downfall to within few months, he goes into a dialysis program, or the strategy has to push this graph up and up. If a person is very fast, it has to go into fast, and slowly we should try to retard the progression. And this is the difference is because of the heterogeneity of the etiology of